And I'm very, very pleased to introduce the next speaker, Dr. Coen Butters. He's a paediatric infectious diseases physician and general paediatrician. He's clinical lead of the Hunter New England Immunisation Service and Department of Paediatric Infectious Diseases. He combines his clinical work and research at the Murdoch Children's Research Institute and teaching at the University of Newcastle. So please welcome Dr. Coen Butters to the stage. He's going to talk about RSV. Thank you, Coen. Use the microphone. Yeah,
lovely. Thanks very much. Well, thank you. Thank you so much for having me. It's such an honour to be here. And I feel like I've got the pre-coffee slot, so I hope everyone's okay to bear with me. I was slightly distracted during David's talk trying to imagine a skinny guinea pig, and I just can't quite get my head around it, but I'll leave that thought with you. So I have the opportunity to talk about RSV prevention, and I think it's such a unique opportunity to talk about a brand new vaccine and immunisation that's been introduced for something that's been introduced so effectively in Australia. And we're very lucky to live in this country, I think, and that's one of the things I've reflected on over the last 2 years. And I really have intentionally put in bold what we have achieved, because this is such an example of what can be done by partnering with community organisations, GPs, AMS and nurse immunisers out there to very quickly get a vaccine, to provide education and make sure that we're providing the right information to families to provide good RSV protection. So this is a wonderful painting. This hangs in the gallery in Adelaide, the Gallery of South Australia. And I encourage you to have a look at it. It hangs in their foyer. But on that background, I just wanted to start by acknowledging the lands of the Camilleri people, but where I work, the Awabakal people, and in particular to acknowledge the disproportionate burden of RSV disease in Aboriginal communities in Australia. We know that much more Aboriginal children each year are admitted to intensive care with RSV and have longer hospital stays. And I think it's really important to found our talk today in that piece of information. So I have no conflicts of interest. While it'll sound like I'm here promoting Beyfortus and Nirsevimab, I have no association or conflict of interest. But I do want to acknowledge Associate Professor Phoebe Williams, Archner, who's in the audience, Dr. Jean Lee Kim Moy, and NSIRS for providing some of the slides today. So we'll talk about what RSV actually is and why it causes such serious disease. We'll talk about the Australian and international burden of RSV, immunisation impact in Australia and the latest data around that, and then pause for a second and talk about challenges and future directions for RSV prevention in this country and globally. So many of you who have worked in clinical space, or indeed any of you that are parents, will know RSV disease and the impacts this has on children. And it varies from upper respiratory tract infection through to lower respiratory tract infection, more seriously, apnea and pauses in breathing, and in a small proportion of infants, the need for mechanical ventilation, intubation, and intensive care admission. But also off the back of that, we know in a number of infants with RSV infection, they'll be prone to secondary bacterial infections, and particular childhood pneumonia is really often off the back of viral illness and the insult that causes. So I think here we have an opportunity not to just prevent GP and ED presentations, but also potential to impact on pneumonia. The other thing that I think is perhaps underappreciated is the impact that RSV has on wheezing illnesses. So here we have a healthy child, along comes RSV, and through that genetic predisposition, we have alteration of the immune response and an increased risk of lifelong asthma. And so in birth cohort studies, so importantly, these are association studies, in children with severe RSV bronchiolitis less than 1 year of age, there's a 48% risk of asthma in that population. And in a large US birth cohort, not being infected with RSV was associated with a 26% decreased risk of asthma. So pushing things down the road a bit and preventing profound RSV infection in early life has the potential to reduce lifelong asthma risks and repeated presentations for wheeze. And we know that this association holds true in low and middle income countries. And as we have increasing impact on immunisation through reducing rates of pneumonia, the next component is dealing with the wheeze and asthma that causes presentations and management. In countries like the Solomon Islands, where I worked for a period, we were still managing asthma with oral salbutamol tablets. So reducing asthma presentations is going to be critical. So let's look at the RSV burden right here in our country. So RSV disease is ubiquitous by 2 years of age, but about 1 in 50 infants are hospitalised by 12 months of age. So this is a common cause of hospitalisation. There's a much higher burden in Aboriginal and Torres Strait Islander infants, and the hospitalisation rate is over 3,500 per 100,000 the population. This is older data from around 2019, and at that stage, the cost of an admission was 12,000. It would be well over that now, 15 to 20,000 of an index admission. So if we look nationally, that's up to $90 million nationally we're spending each year in managing children in hospital for RSV. But when you add in the fact that they come back with representations and the need for management of their wheezing episodes, it's over $120 million. So you can see from an economic perspective that providing good RSV prevention in the first 12 months of life makes sense. So this is national data, and this includes adults. We can see this dramatic increase in RSV infections. It varies slightly year to year, and of course this data is impacted by the time that we had physical distancing off the back of COVID-19. You can see these huge peaks that occur around the autumn into winter months. The predominant impact is in those less than 6 months of age when you look at hospitalisation and ED presentations. And so that's where the target of our RSV prevention really is. This is from the Sentinel Children's Hospital sites in Australia from the 1st of January. And you can see here almost 6,000 RSV admissions in children, 7% requiring intensive care, and 0.1% dying related to RSV infection. Zooming out a little bit, I wanted to talk about the RSV burden worldwide in children under 5. So each year there's 33 million estimated RSV infections, 20% in less than 6 months of age, 3.6 million RSV-associated hospital admissions, and over 100,000 RSV attributable deaths, including 45,000 deaths in infants that have not made it to 6 months of age. So the overall global mortality is thought to be around 3.6% in those less than 6 months and 2.3% under 5 years. This is from a Lancet paper, and the authors conclude that that's almost certainly an underestimate because of the lack of autopsies, the availability of diagnostic testing in many of these countries. So let's talk about how we address this problem and what we've been able to achieve in Australia. So this is the current immunisation landscape in Australia. So we have a mix of products. So firstly, Abrivzo. Abrivzo is a recombinant vaccine, there's an error in that slide. Nirsevimab, a monoclonal antibody, and Arexvy is a recombinant vaccine. In Abrivzo, we have antibody directed against the Nirsevimab antibody directed against the pre-fusion F protein in the target 0/site. It's focused on infants less than 24 months. Abrivzo, we know, has been introduced as a critical part of the pregnancy-based program, but is registered but not funded in adults over 50 years, and Arexvy similarly registered but not funded. So we have a combination of products that are available in Australia, but importantly, Nirsevimab is based on state-based immunisation programs. Looking at the data for Abrivzo, that recombinant vaccine, we know that in 3,500 vaccine exposed and 3,500 negative into infants, this was very effective in reducing severe disease and very effective in reducing medically attended lower respiratory tract infection within 90 days. And overall, purely using Abrivzo with passage of antibody across the placenta to the baby, we were able to reduce the risk of infant hospitalisation by 60%. And that effect lasts out to 6 months in that critical window. Looking at Nirsevimab, so this is focused on the pre-fusion component of the F protein, which is critical to binding and allowing RSV to get into cells to join to reproduce and to cause the airway damage. We know that the particular pre-fusion F protein component, the 0/site, has very high neutralising potency, and you may remember palivizumab, which has previously been used for many years in the highest risk population. It has much greater neutralising potency than that particular antibody preparation. And we know that this particular site is stable amongst both RSV-A and RSV-B, and between seasons that there's stability of that site. So we are certain that this antibody preparation is going to continue being effective across the years. In Australia, we've focused our eligibility on the highest risk population. And so we're focused on those that are preterm, less than 32 weeks, those with hemodynamically significant congenital heart disease, those that have chronic lung disease, particularly those that require home oxygen, children with neuromuscular disease, spinal muscular atrophy, weakness, children with underlying immunosuppression, including those young children who are commencing cancer therapy or higher doses of steroids, children with cystic fibrosis, particularly those children with more severe phenotypes, and then children with a range of underlying genetic diagnoses that we expect would put them at much higher risk, specifically trisomy 21. And then focused on providing additional immunisation to Aboriginal and Torres Strait Islander infants, knowing that they have much higher risks of hospitalisation and intensive care admission. So this is from the Australian Immunisation Handbook. And so for infants that have additional risk conditions, we have really a belt and braces approach in which they're both getting abrivso and nirsevimab to provide long-lasting protection. And then there's a subgroup who are born just too early to allow that 2-week passage of abrivso antibody manufactured by the mum of antibody levels and transplacental passage, or those mums who are immunosuppressed, or that rare situation in which a mother might have had ECMO or been admitted to intensive care and is not thought to have good antibody passage. And so in those infants, we're providing nirsevimab as a booster. So let's look at the nirsevimab evidence to date. And so this is one slide summarising all the papers. And so the first of those is the MELODY, and these follow a pretty clear theme in their naming. So this was almost 1,500 infants greater than 35 weeks, and we had a vaccine efficacy of 76% for medically attended lower respiratory tract infections. So that's a primary healthcare or emergency department visit. And then we had HARMONY in over 8,000 healthy term infants. There was a vaccine efficacy of 83% for hospitalisation and 75% for severe disease. And then finally, looking at the preterm infant group in those 29 to 34 weeks, we found good vaccine efficacy for nirsevimab at 78% for hospitalisation. So moving now to the impact that those of you in the room that have given nirsevimab, that are giving abrivso, and we know a lot of this is happening in the community, it's important to understand the impact that is already having on hospitalisation rates and potentially the longer term impact that might be having on recurrent wheezing and asthma. So this is abrivso given this year. Over 110,000 adult females have been provided abrivso. You can see the bulk of that workload, 44%, is occurring in general practice. Small proportion, interestingly, happening in pharmacies, and then some happening in public health units, a portion happening in hospital at 21%. We've got good Australian data through Ausvac Safety that abrivso is a very safe vaccine associated with low rates of adverse effects. Around 0.9% received abrivso, saw a doctor or needed to go to the emergency department in the days following vaccination, and fewer than 1% or another vaccine alongside with another vaccine ended up going to the emergency department or seeing a GP. Let's have a look at the impact now of nirsevimab in particular during the 2023 immunisation program. Spain really led the way here and had really excellent early rollout of nirsevimab. And so they were able to immunise or provide vaccination to 91% of eligible infants, with 82% effectiveness against hospitalisation and 87% effectiveness against severe disease requiring hospitalisation and oxygen therapy. And from that study, we found the number needed to immunise to prevent one hospitalisation was 25. So pretty good numbers in terms of outcomes. And you can see here the previous seasons without nirsevimab in place in the purple down through the blue, and then the impact immediately that nirsevimab has on hospitalisation rates. And so really kind of flattening the curve completely through that rollout. This is a slide courtesy of NSERS, and I just really want you to focus on the purple numbers, which is effectiveness against hospitalisation. So you can see here the Western Australian data. We've got 88% reduction in hospitalisation through implementation of nirsevimab. Spain, USA, You can see here in the US in the dark brown at 70% the effectiveness against emergency department visits. So I think that's the other important fact here, looking at emergency departments across the country that are continually reported to be stretched and under significant stress day to day. We can potentially make an impact on that winter surge and the impact that potentially has on other patients as well through transmission in the community. This is looking at rollout this year of nirsevimab, and you can see overlaid at the top the numbers provided in each age group. So 18,500 doses of nirsevimab provided already in infants less than 2 weeks, so birth cohort, 2,000 in the slightly older group, over 25,000 doses in those aged 6 weeks to 8 months, 60% provided in general practice. So they're really providing the bulk of this work. And then 8 months to 2 years, 58% provided of 1,900 doses. I think one of the things that I've been thinking of and in talking to families through our immunisation clinic is how you access nirsevimab in the community. And I think that's variable, unfortunately, on where you live. And I think the reality is for some families, paying the cost of a doctor visit to assess for nirsevimab, where that's not bulk billed, and then coming back when the nirsevimab doses are ordered in to make sure they have that nirsevimab. Not every family is going to be able to access that. And so I think as a hospital, we're really stepping in to fill some of those gaps for some of the most vulnerable families, to catch them during their routine outpatient appointments, to make sure we have nirsevimab available on the spot to try and catch up these families. But I think there is risk for inequity to start creeping into the system with that kind of delivery process. In terms of safety of nirsevimab, so last year Western Australia provided over 23,000 doses, and we can see there were reported adverse events in just 25 and zero serious adverse events. Mostly that was rash, a little bit of irritability and fever, but a very well tolerated antibody preparation. So moving to current data, this is RSV infection in New South Wales starting in 2024 and moving our way through. Importantly, this includes adults as well. But you can see here in the orange line following that through, this softening of the curve as we introduce RSV prevention. Western Australia have provided, as I said, almost over 24,000 doses, including 11,000 newborns, and we're able to reduce hospitalisation by 83%. And you can see again in the orange down the bottom, the immediate softening of the curve for hospitalisations. Queensland similarly this year has a remarkably different curve. You can see for their impact on hospitalisations, the red line in those less than 6 months, that really we're talking paediatricians who are wandering around the wards wondering where their RSV disease is. You know, our work has changed significantly during winter because of this vaccine program. It allows us to focus our efforts on other aspects of routine preventative care potentially, and also other aspects of acute medicine. So let's talk about some challenges. So there's certainly local challenges to upscaling RSV prevention. I think we talked a little bit about that already. I think firstly, and this was come up multiple times already this morning, addressing vaccine hesitancy. And I think a part of that is access to information, making sure we have that access, that information available at the point of care. And then I think moving forward, and I don't work in a policy space, but harmonising a national approach to RSV prevention. So at the moment, we have a national immunisation program that supports Abrivzo but doesn't support nirsevimab, and we have huge differences in the states in their provision. Last year, there was a race to access nirsevimab, and so our doses, we were able to get in and use doses left over from Western Australia and relabel doses imported from Germany to very quickly roll out nirsevimab, but we don't want a situation which has races between states to access nirsevimab. The third thing is ensuring equitable access across Australia, and so I think access to general practice remains critical for access to these products. We need to ensure that this is available in all areas. This is a bit hard to read, but earlier in the season, we built a heat map looking at where nirsevimab was being delivered in the community. And so you can see this focus around urban areas and these large gaps around access to nirsevimab across the Hunter New England area. So I think it's also important to stop and think about the impact that nirsevimab could potentially have in low and middle income countries. So this is Honiara. This is the central hospital in the Solomon Islands. These are the dogs moving between the wards. Just out of focus there is the ominous black cat that sits outside the tuberculosis ward each day. This is an infant who's born prematurely, but you can see here we've got some respiratory support. What's not shown and just out is what that looks like. So these are reused plastic nasal cannula that are washed and hung in the sun after each use. They have about 10 of them that they move between infants. That oxygen's being delivered by an oxygen concentrator that's dependent on power, that's dependent on delivery of power from the local plant, maybe the solar panels working. And we're providing bubbles CPAP through an oxygen supply using a recycled shampoo bottle to provide CPAP and pressure. So this is the kind of respiratory support that's available in many parts of the world. So you can understand the mortality for something like RSV bronchiolitis is significant. So I think that's the big question now, is how do we get these products to places like this that critically need them? And so there's a framework here based on other vaccine deliveries about how we can improve equity across the world. And so the first thing is accessible education, information, and immediate counters to misinformation. And when I do our vaccine hesitancy clinic, I sort of am never quite sure how to be prepared, because the things families ask me about are not the same questions that I might have had about a vaccine. They come left of center, does this cause this? Does hepatitis B vaccine cause limb loss? But all sorts of different things. And so we need to be prepared and knowledgeable. The second thing is making this a part of national and global health strategy, thinking about that RSV impact and what we can really do here by working together. And then affordable RSV vaccine and monoclonal antibody pricing models, including cross-subsidy. I like the idea with the significant markup that we buy our nirsevimab for in this country, that really for every 2 doses, we should be giving 1 dose to the Solomon Islands. That's how this system should work. We want there to be equitable allocation frameworks for RSV immunoprophylaxis, so there's never an immunisation race. We could consider incorporating RSV immunoprophylaxis into the existing global vaccine distribution systems. And so we know by using the COVAX system that we're able to get COVID vaccines to many of these places. And so that same framework and that same logistical systems could be used for distribution of RSV vaccines. Promoting local manufacturing, finishing and packaging of nirsevimab. This is not a challenging product to make, so it's something that could be made locally. And then there's some new questions. So questions that I have. Might have to click, sorry. Thank you. So the new questions I have, are there populations beyond 2 years of age that would benefit from nirsevimab? So really 24 months is our cutoff at the moment. But I think it's important to look at those patients that are hospitalised beyond that. There's probably children with specific comorbidities that should be getting nirsevimab. The second thing is, will these RSV prevention programs that we've rapidly implemented so successfully in Australia modify wheezing and development of asthma in children longer term, considering we have extremely high rates of asthma in many parts of this country? The next question is whether severe RSV disease in children who are immunised a marker of underlying disease. So I think we're getting to the point that it would be unusual for a 6-month-old who's had nirsevimab to be admitted to hospital. So I think as paediatricians, we're going to be thinking about, why has this child ended up? Because that's an unusual situation for us. Having previously had wards full of RSV, this is not the norm anymore. And then, is an RSV vaccine feasible for infants? Because at the moment we're getting by on an antibody preparation that only lasts 5 to 6 months and we're needing to top it up. Can we successfully introduce a vaccine? So this is the vaccine pathway, and you can see some of these move from phase 1 into phase 2 and then fizzle out in the red. But then we have in the blue vaccines and antibody preparations that are rapidly moving beyond phase 2 into phase 3. So there's lots of opportunities here and lots of products in the market. The most interesting part here is the role that live attenuated vaccines are potentially going to have, and particularly the ability to give live attenuated RSV vaccine to young infants to provide longer lasting protection. Excitedly, live attenuated intranasal vaccine has just been trialled in infants for the first time. This was published in August of this year. This was an extremely well-tolerated, well-accepted vaccine and provided excellent antibody levels to both RSV A and B. So I think there's definitely things on the horizon, and I think what we're doing now is working and fabulous, but things are going to change. So in summary, RSV causes significant impact in Australia. It's responsible for many infants being hospitalised each year, over 6,000 hospitalisations already this year, a significant burden both in Australia and low and middle income countries, including a significant mortality rate. The immunisation program we've rapidly rolled out in Australia is having a significant impact in that it's reduced hospitalisations, it's reduced ED presentations, and really changed the epidemiology in Australia. But there are challenges in thinking about what our vaccination program here will look like into the future, but also how we get vaccines to other countries. Thank you.
Thank you, Coen. That was spectacular. So good to see Honiara Hospital in your slides. That's across the road from the office where I work. That's brilliant. Some real themes coming through. So Aboriginal immunisation are really, really important. So the theme for this conference is country roads. So country roads is really about access, getting people to your clinic, you getting to them. And that's what Coen's talked about, is access for these vaccines. How can we get these vaccines into people? So when you think about country roads, it's really about that access problem. And vaccines are just amazing. So David talked about measles disease can lead to lifelong susceptibility to other diseases. Coen just talked about RSV infection potentiating further asthma. So the vaccines we give protect against the things, but also have these other flow-on benefits in terms of general health, which is absolutely fantastic. And the other thing is, like David's talked about measles that we've had for decades and decades, but if you speak to people who worked in, and yourselves, in kids' hospitals, 10 to 15 years ago, we started to see the winter peaks of rotavirus diarrhea infections just plummet. And we don't have that in kids' hospitals now. And now Coen's talking about himself and his colleagues not seeing RSV infection in kids' hospitals. So vaccines take the burden off the tertiary system so that we can look after kids who've got things that we can't prevent. So if we can prevent this stuff, it lightens the burden on the whole health system. So let's do our colleagues working in the hospitals a favour and vaccinate everyone we can. Let's get some questions for Coen, please.
Hello, I'm a midwife that works in a birthing environment, and RSV suddenly, like you said, quickly rolled out. What are your thoughts about some people have it antenatally, some don't, and then their baby requires it? Is there one that was optimum to the other?
So I think the vaccine efficacy is very similar between both the Abrivzo and the Sivimab. I think it's a unique opportunity in which we're able to offer families both, and they're able to choose. And so this has been a real test, I think, of whether mums would prefer to have a vaccine during delivery with their baby and transplacental delivery of antibody, or whether they'd like to give an extra needle to their infants. And I think they've sort of spoken, and uptake of Abrivzo, I think, has been quite remarkable. It's a good time to sort of acknowledge the work that midwives are doing, because they're providing all this education as part of busy antenatal appointments. And then in amongst all the postnatal delivery care, checking an infant, checking mums, they're suddenly being asked to talk to families about Nirsevimab, screen for eligibility. So I think we're asking a lot of midwives here, and thank you for your capacity and willingness to take this on.
So one's not more effective than the other. One, like if one has it antenatally, it's not going to be less effective than the baby getting it later.
No, that's right. I think the important thing is there that, you have a vaccine product for RSV, and ideally that's given at least 2 weeks before delivery to allow those antibody levels to develop and for there to be passage.
Sorry, just a quick question. I heard you mention that you do a vaccine hesitancy clinic. Can you just talk a little bit to that and how people engage with that service, or they get referred to that service?
I feel like our referrals are about to go up, but here we go. Kylie won't be impressed with me mentioning this, but anyway. So, one of the things, so a couple of years ago, and Kylie's about to talk to this, but a couple of years ago, we were funded through the Ministry of Health to set up an outpatient immunisation service, and really to try and capture vulnerable infants who are joining our outpatient service. Off the back of that, we've started offering vaccine hesitancy appointments, and Kylie will talk to that, but you're welcome to refer through RIMS, through John Hunter Children's Hospital, for families. And the way that we structure that is really a conversation around immunisation with no expectations. I think what we've learned from that is the importance of really being flexible. And so for us, it's a win that if we get any vaccine, any single antigen, to be able to be provided through that clinic. But you're welcome to refer for that for tricky families. We put aside an hour. It's both a nurse immuniser and myself sitting down with a family.
Do you know if there's anything happening for the elderly and RSV as far as access, free access?
I'm looking to Archana because she works at NCS and is in that space. I have to admit, once I stopped training in adults 15 years ago, I stopped paying attention. I have to admit, I'm really a children's doctor. But I think that's an important area. I think one of the interesting things that came out of COVID is people decided that they would start doing RSV testing in adults, which just really wasn't a thing to do PCR. And what we discovered was, firstly, a significant burden in the over 70s, that actually many adults were admitted to hospital with RSV, often presumably transmitted through their grandchildren. But we also discovered that there's high rates of transmission of RSV within hospital systems, and actually it's making adults very unwell. So I think economically, it's likely to make sense, but getting this vaccine funded as part of the National Immunisation Program is the next kind of policy decision, I think.
Hi. Have you noticed, this is possibly an unusual question, but in the discussion of giving mums their immunisation or protection for RSV and therefore their infants, have you noticed any hesitancy with regards to mothers declining the immunisation because they know now that they have left the winter period because of their current gestation and therefore going into the warmer months, and therefore have missed that peak incidence? The only reason why I'm asking this is because I also work with children 0 to 5 in the community. I do some home visits, and I do note that at times I will meet with families that they've said, oh no, we haven't had it. We've gone through the winter period. It's not as, in their opinion, as important to get the RSV because their babies are born in the warmer seasons.
Yeah, I think the pressure is taken off families a little bit, because where we started it was that there was RSV in daycares. Daycares are notifying families constantly about RSV. There's always a friend with bronchiolitis. And so the pressure is there. It feels very real, the importance of immunisation. But we do know this is very seasonal. And certainly with Nirsevimab, we have capacity, because it's a hospital-based program in a lot of instances, to switch this on and off based on the seasonality. The thing we're getting with climate change is slight shifts everywhere in Australia. So what we're going to need is capacity to monitor RSV in real time and be able to switch on this program and say, actually, we're having an early season here. Let's ramp up our Nirsevimab delivery. I'm not sure how effective that's going to be. But if we move to maternal vaccination, what was decided on a national scale was really, for maternity programs, it doesn't work to suddenly say, oh, today's the time you give the vaccine. Actually, now we're not giving the vaccine. And the decision was made that we just run that continuously from a practical point of view. But I think families are onto that. And I think absolutely the risk dips, and it dips dramatically. You can see those numbers really peak. So I think in many ways that's a very reasonable decision for mums to make, is to say, actually, on a risk-benefit basis, we're out of RSV season now, and I'm not going to have that vaccine.